We've gotten to establish that restrictive cardiomyopathy is a condition where, yeah, the heart muscles, okay, will I say the heart size is the same, okay, approximately the same size, all right, if you say that. But the problem is what? The heart is not relaxing to get filled up with what? Much more blood when the need arises. Okay, yeah. So there are different types of heart diseases or disease of the heart muscles, right? So this one is dilated. We say that the chambers are being enlarged. This one is hypertrophic. The muscles are getting thick. But restrictive, the heart is kind of like almost like the normal size, right? But the only problem is the heart cannot relax further than this. Okay, the muscles are stiff. All right, the heart is now having a definitive size like a bone, which is not supposed to. All right. So we are now talking about the pathophysiology. Pathophysiology is more of like step by step to how this word crazy condition actually came to be. All right. So we said that what this restrictive cardiomyopathy is a disorder of the myocardium resulting from increased stiffness of the myocardium, and this will cause an increased ventricular pressure, all right, with small increase in what? Ventricular volume. So that means what? Pressure is now much in the heart. The heart is not relaxing like a muscle again, all right, which is not supposed to be. So ventricular filling is accentuated during early diastole. You know, diastole is when the heart relaxes to get filled from the atrium. Okay, so normally the heart should relax, but we are now saying this relaxing has a problem now. Okay, so ventricular filling is accentuated during early diastole, terminating at the end of a rapid filling phase with ventricular pressure tracing, revealing what? A characteristic diastole, all right, or a pattern mimicking that of a constrictive pericarditis. So instead of the heart to now relax or the diastolic stage to now happen from beginning to end, the diastolic stage could be just very small, all right. So that means the heart is not relaxing more than the usual for blood to fill it, okay, and that's usually a problem. Now, although the heart keeps pumping, it does not pump enough blood to meet the body's need. Do you know why? I must receive enough for me to pump enough. So the heart is not relaxing to get filled to the maximum before pumping out the maximum. All right. So the heart is just pumping what it is receiving. I know sometimes the heart pumps and even remains some in it. Okay. So in the early clinical phase, systolic function is preserved in restrictive cardiomyopathy patients. So early, the ability to pump out completely will still be preserved. But as the restrictive cardiomyopathy progresses, there may be a variable systolic dysfunction accompanied by what? Symptoms of reduced cardiac output. So as the restrictive cardiomyopathy goes on, all right, the output will later on now be affected. Okay. So in rare cases of restrictive cardiomyopathy, in the setting of what? Infiltrative cardiac disorders such as what? Amyloidosis or sarcoidosis, there may be an increase in what? Wall thickness, but not as pronounced as the extent observed in patients with what? Hypertrophic restrictive cardiomyopathy, right? So complete heart block in some patients will result from what? Endomyocardial or fibrosis on the sinoatrial or atrioventricular nodes. All right. So the big deal is what? At least you guys know what restrictive cardiomyopathy is, and at least you can just be able to just talk about the early phases, late phases. That's all. Early phases, there's restriction, but cardiac output is preserved. Then later on now, okay, the whole thing is now spreading, that the heart is not relaxing properly. Even the pumping out is now being affected and all that. All right. So I think this is just a briefing of the pathophysiology of what restrictive cardiomyopathy.